probably the left heart border and the left hemi diaphragm. The heart size is also enlarged. Um, the heart size is also enlarged. In my I just want to zoom up the image a bit. Like in my routine practice, I would like to zoom up the image uh, to look for any associated findings, like to look for curly V lines and the costophrenic angles. The bilateral highlight shadow also appears to be prominent. Um, there is, I think, there's mild enlargement of the. Uh, there's mild widening of the superior mediastinum also. Uh, so,
So
so
what's
the
your
rest of the
differential diagnosis?
yes, the rest of the visualized soft tissue and the bones appear normal. So in my so to sum up, in this patient with mild cardiomegaly and indistinct costophrenic angle and prominent reticular markings, my first differential for this case would be uh, prominent interstitial marking because of cardiogenic pulmonary edema. Second differential,
Yes.
if the for the prominent interstitial marking, the patient has some lung malignancy. If the patient has a history of lung cancer, it could also be because of lymphangitis carcinomatosa. Uh, so I would convey my finding to the referring physician. Would like to correlate this with the previous radiographs if available for this patient. And
Could you tell
would
me one sign in this X-ray against the pulmonary edema? One sign, two
um,
sign, not one sign. Two sign
the
against pulmonary edema. Mhm.
I think against pulmonary edema, the prominent highlight shadow. No, but
No,
no, that is
no,
possible
this
in the
is with. Mm,
cardiogenic pulmonary edema can also present that way. Mm,
yes,
say, loss of lung volumes,
yes, excellent,
loss of
excellent.
lung volumes
Second,
bilaterally. And second is, I also suspect there's left hilar lymph. I mean, I noticed that there is some bulky left hilar. I suspect that there is some mediastinal lymphadenopathy also. So I
no,
would
no, no
convey.
lymphadenopathy, no lymphadenopathy. There are another very important signs that you can exclude pulmonary edema, or be sure at least, يعني, or be suspicion this is not a pulmonary edema.
So,
This is something else. Mhm.
so I think there are no pleural effusions. There's no kyphilization of the vessel probably. Um, but yes,
Mhm.
there's cardiomegaly. Definitely, I suspect that the patient has cardiomegaly. Um,
So your differential will be
Um, yeah, so it could be lymphangitis carcinomatosa if the patient has any history of lung cancer, or
okay.
I would
Second,
convey my. And the second could be prominent interstitial marking because of
yes. Mhm.
some pneumoconiosis. But yeah, or it could be
Okay.
sarcoidosis. Also, sarcoidosis could be a possibility if the if it is
Mhm.
second differential could be sarcoidosis because of prominent interstitial marking in this case.
What else? Give me a last differential.
Uh, lymphoma, sarcoidosis, lymphangitis. These are all the things. Or it could be a. Yeah, that's all I
No
can think
problem.
of.
No problem. No problem. No problem.
So I
Second
would like,
case. Mm.
yeah,
Second
I
case.
would like to see the.
Uh,
Yeah,
mm.
like, can I see the like if this is the first presentation, I would suggest HRCT for this patient.
Okay. Okay. 6 years old female patient
Okay.
with dyspnea.
Okay, so I'm provided a frontal chest radiograph of a 60 years old female patient who has presented with dyspnea. Looking at the radiograph, I noticed that there is some opacity noted in the right upper lung,
Excellent.
just beneath the anterior end of the right first rib. Uh,
Mm-hmm.
Apart from this, I'm not able to see any opacity in the bilateral lungs. Uh,
Mm-hmm.
I also noticed that there
So
is some. So in this patient, it could. I just read the history. The patient had some history of breast cancer. This could represent in a patient with history of breast cancer. This could represent a metastatic lesion, or if the patient has a constitutional symptom, uh, this could also represent.
what will you do next? What will you
So
do next?
I would advise contrast and CT chest for the confirmation of the finding and the correlation with the previous images if available.
Okay. We finish this. 50 years old.
Also, I'm provided a frontal chest
50.
radiograph
Mm-hmm.
Telugu. So this is a frontal chest radiograph of 50 years old male patient who has presented with dyspnea. In this radiograph, I noticed that there is my first on the first view, I noticed that the patient has cardiomegaly. Um, Also, there are prominent interstitial marking with alveolar opacity noted in the bilateral lung in the perihilar distribution. Bilateral costophrenic angles are clear.
Mm-hmm.
Uh, there is also first I should have so I noticed that there is also tube endotracheal tube noted in the trachea, um, which is placed correctly above carina. Um, the visualized bones and the soft tissue appear normal.
Mm-hmm.
So, to sum up, uh, yeah, one more thing I noted in this patient is I think there's widening of the right paratracheal stripe. Uh,
Yes. What is
so,
this? And look under the right hemidiaphragm.
okay, so under the right hemidiaphragm, I noticed that there is some calcified, I think there's some metallic density noted in the below the right hemidiaphragm.
What's your differential?
First, like on the first instance, I thought it could be mild cardiomegaly again with the cardiogenic pulmonary edema. But like
Mm-hmm.
looking at that, since the patient has prominent right
Thank you,
paratracheal,
Dr. Amiga.
yeah.
Your 15 minutes finished.
Oh,
Thank you.
yeah. Thank you so much.
Really, you did very well, except in the last case. And I gave you this last case to give you when the examiner. I'm not an examiner. I'm originally your colleague. I'm speaking
Okay.
like examiner now. When the examiner give you something difficult at the end, this means he wanted to give you 7.5 at least. Really. So be happy. This is one of the most difficult case, or this is it may be the most
Okay.
difficult case of today, and mistakes that we are continuously doing. Satisfaction of search. Okay, this patient presented with fever and they have some airspace partial opacity. This is it may be some element of infection. Okay, but look here, this is the nasogastric tube at the right hemidiaphragm. So there are some element of situs ambiguous. This is the point. And if you look here, this is okay. You picked up it, but you can't interpret what this is. This is right paratracheal opacity, but actually this is right-sided aortic arch. Okay, despite this is a levocardia, but the stomach is seen in the right under the right hemidiaphragm. So this is a case of situs ambiguous. Yes. Okay. I know this is very difficult. I know, but I give you a scenario mimic the Viva case of
Yes.
it. Okay. Um, okay. Then the case before, you did very well in this case, but I will give you only 6.5 because you forget to start with this. Despite I didn't hide the history. You should, when you see this, this is a status post-right, even lumpectomy, breast operation, anything. Tell me anything about you see this surgical grips. Uh, I think in America, first statement to be written in the chest X-ray if there are mastectomy or not. It's very important. يعني to imagine how it is important about telling if this patient has any relation to breast cancer or not. Then tell me other finding. Okay, there are opacities. This is maybe metastasis. Very correct. But don't forget it. It is lost you many marks because without telling this, anybody can give any other acceptable differential diagnosis, infection, TB. Okay, okay. But when you see it, you means that you are in the correct track from the beginning. Um, so this case, I will give you only 6.5 because of this
Oh,
point.
yes, yes.
Okay. In this case, another tricky case.
We cannot see this.
Uh,
We cannot see the cases, Dr. Rami. The last case is still visible.
okay, okay. This one.
Yes, now is it? Now
Mm,
it is visible.
yeah. This is another tricky case, another trick in my session. I show you in the beginning this one, and you very easily pick up it. This is usual interstitial pneumonia. Okay, this is
Yes.
very easy startup case, and most of the examiner start up with easy known case, very obvious finding. But I want to make you a trick. I bring you also here a usual interstitial pneumonia, but only CT, only X-ray. I ask you, why? Give me a sign. This is not a cardiac pulmonary edema. If you see here, if I am a candidate, this is bilateral, maybe asymmetrical reticulation and cystic changes in both lung, more obvious basally, and more obvious at the right lung. And I suspect there are some opacity here in the left lower lung base, maybe retrocardiac. Okay, very excellent. And there are obscuration or haziness or shaggy cardiac border. This is one of the most important signs to differentiate pulmonary edema for interstitial from interstitial lung disease. Okay, at this point, if you get this from the beginning, class, you tell me that I know my first differential diagnosis should be interstitial lung disease. Then I will put others like cardiac pulmonary edema, whatever. Okay. Then there are cardiomegaly, there are pulmonary hypertension, enlarged hilar shell. Okay, okay, okay. This is my differential diagnosis will be first is interstitial lung disease complicated by heart failure or cardiomegaly or whatever. I will do a high resolution CT scan of the patient, and also I will compare with previous images, and I will ask the patient of any history of, and you pick up it, all of this. Ask for pneumoconiosis, but there are no calcified plaques. But from the beginning, you should put yourself in the right way. Okay.
Yes.
Okay. Uh, this case, okay. Also, this case you pick up. You start very good at the beginning. There are cardiomegaly. There are maybe prominence here. It looks like pulmonary hypertension. And then you immediately told me this is unremarkable bone or normal bone. No. Uh, please ask the examiner to zoom, or ask him, can I zoom? In the actual examination, he will let you for at least zooming. He will not ask you what are you doing. Zoom whatever you want. Zoom at both apex. Zoom at the bone. Zoom also at both hemidiaphragms. This is very important. Do you know if the examiner the examiner are watching your procedure. He is very happy when he see you do like this because this is the actual. He know from your attitude or from your procedure that oh, this is expert. This candidate is regularly work. He is not only study at home. Okay, so you pick up the H vertebrae,
Remy,
but with some help.
your face is not visible on the screen.
Ah, sorry, sorry.
Yeah.
Zoom whatever you want. The examiner will be happy. He will tell himself this is candidate is working regularly. You pick up, but with help. This is H-shaped vertebrae. If you look here at the right, the left hemi diaphragm, there are some soft tissue opacity. It may be the spleen. And I show you here the lateral. There are some element of mild splenomegaly, and this is acceptable in the early stage of sickle cell anemia. Okay, the first case, you pick up it very well ready. But I'm waiting from you to tell me, please, doctor, I wanted to check if there are pulmonary hypertension or not. The cardiac size is almost normal. I will measure the diameter of the pulmonary artery. Okay, I will give you 8 by 8. Okay,
Okay.
but generally, Dr. Omega, you did very well. At least I will give you, if there are, this my one room, 7, 7 overall. Very well, very
Thank you.
good. Uh,
Thank you.
Next candidate.
I think Dr. Roshni is the next candidate.
Yes, doctor, I am here.
Okay, 6 years old, mm, patient complaining of cough.
I cannot see the screen. Oh,
1 minute, 1 minute, 1 minute. Okay, 6 years old patient
okay.
presented with cough. Yes.
I am provided with a frontal radiograph of a 6-year-old patient who is presented with a complaint of cough. Looking at the radiograph, I have first noticed there is an opacification noted in the right upper and mid zone. Um, it is it has a sharp medial margin, and there is no calcification within it. The overlying ribs appears normal. Um, uh, the bilateral costopharyngeal angles are clear, no pleural effusion, no cardiomegaly is noted. There is no any evidence of pneumothorax. So in this patient with opacification and complaint of cough, I am thinking of this can be a round pneumonia if patient have a complaint, if patient have a history of fever, or this can be a hydrated cyst, or this can be a bronchogenic cyst. Um,
What
so I will
else?
inform my
What will you
finding.
do next? What will you do next?
I will inform my finding to the referring physician and refer this patient to the respiratory unit for further management. And antibiotic treatment will be given for 6 weeks, and follow-up radiograph will be taken for this.
Excellent. This is the CT of the same patient.
Um, okay. I am provided with a CT scan axial images of the chest. Post-contrast images, I can see that there is an opacity, there is a cavity lesion with the air fluid level is noted within the right upper lobe. Uh, it
Mhm.
has upper lobe, so I can see the air bronchogram within it. So this can be a lung abscess, um,
Or
or this can be some congenital condition like CCAM or
yeah, okay. What will you do next? What's your other differential diagnosis rather than abscess?
other than absent, it can be a cavitary pneumonia, or it can be like patient is a young age. This can be a CCAM, or this can be
Hmm.
yes, this
Okay.
can be.
Okay. What will you do next?
I will inform my finding to the referring physician and refer this patient to the respiratory unit. And I also look the previous imaging and correlate my finding with the patient history. of the patient.
Excellent. Excellent. 60 years old male patient presented with acute chest pain.
I cannot just see the screen.
Okay.
I'm provided with the frontal radiograph of 60-year-old patient who is presented with a complaint of chest pain. Looking at the radiograph, I first noticed that there is mild cardiomegaly noted. There is no any nodular opacity noted within the lung field. There is no any pleural effusion or any pneumothorax noted. Um, Looking at the ribs appears clear. There is no any.
Yes.
There is a reduced bone density as it is can be related to an age of the patient. The joint glenohumeral joint appears normal. So in this patient with acute chest pain complaint, I could not find any evidence of pneumomediastinum or pneumothorax. So for cardiomegaly, I will advise the echocardiography of this patient. Um, uh, Further workup, and I will.
Could
I,
you could you detect any difference between both mediastinum?
um, there is a opacity noted in the right paratracheal region.
Is this opacity or something else?
This is opacity. Looks like an opacity, and
This looks like curvilinear structure. What will you do next?
if patient have a clinical suspicion, so I will proceed with the contrast and CT scan of the chest. For the Okay, and I am provided with a CT scan exit section of the chest, post contrast images. I can see there is a thrombus filling defect noted in the right pulmonary artery and its second order branches. It is completely filling the vessel, so it is an acute thromboembolism. Um, I will, in my routine practice, I will look the lung window to see the if patient have any pulmonary infarction. Um, and also look the heart to see any sign of right heart strain. And I will immediately inform my finding to the referring physician and the on-call team for immediate anticoagulant treatment.
Excellent. What would you look in this CT again, also, other
There,
than hmm, this embolism?
other than this embolism,
Hmm.
I will look the cardiac heart size if there is any right heart enlargement.
And what else?
Uh, the cause for the pulmonary embolism,
Okay, so there are any cause here?
the pulmonary embolism is also on the left side within the pulmonary artery branches within the main pulmonary artery. Um,
Mm-hmm.
but I could not find the cause for as I cannot see any lung mass or so Doppler ultrasound of the lower leg can be done to see the cause or if patient have
Okay.
any history of surgery like recent.
Okay, excellent. Okay. Old age with dyspnea?
I am provided with the frontal radiograph of an skeletal major patient who is presented with a complaint of dyspnea. I can see there are sternotomy sutures are noted, which is consistent with the previous cardiac surgery. Um, and there is an opacity noted on the right paravertebral region, giving a double heart.
Excellent.
Uh,
Excellent.
Giving
Your
double.
differential?
This can be due to a left atrial enlargement or mitral stenosis, or this can be due to a paravertebral abscess or
No, 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 no. You are correct. You are correct. There are another sign for a double enlarged mitral,
yes,
enlarged left atrium or not? What is this? Tell me, please.
there is a widening of the carina, elevation of the left main bronchus.
Ah, And there are another evidence in the beginning. Excellent, excellent, excellent. Guys, I bring some cases to show you how we are the a human being in under stress may be out of the correct way, and despite we start well. Very good, doctor. Yeah, this is a difficult film, but I think you are excellent enough to pick up it. This is a remarkable film. This is not emergency film, not a chronic. This is something you must train your eye to be strong enough to detect minor minors finding. Hmm.
Okay, I'm provided with a
Yeah,
frontal radiograph of an skeletal mature patient. I can see there is an elevation of the left hemidiaphragm. Um,
excellent.
and there is an
Hmm.
air lucencies are noted within the left hemidiaphragm. This could be a bowel loop, likely a Chilaiditi syndrome.
Shall it? Okay, okay, no problem. But this is looks like a high riding column. No problem. What
Uh,
else?
on the left hemidiaphragm is elevated. This can be due to an eventration.
Leave the left frame. There
Hmm.
are another finding.
Okay, I'm looking. I could not find any pathology within the lung, so I will go to my reviews area. The
Yes,
Pisces,
excellent.
the Pisces are clear. The bilateral hyla appears normal. There is no any retrocardiac opacity. Um, both cos
Concentrate on the mediastinum, please. Concentrate
and the media sternum. Uh,
inferiorly. Hmm.
the vertebral bodies appears normal. I there is an opacity noted in the on the right in the retrocardiac area on the right side.
Opacity.
Yeah,
Okay. Large or small opacity.
it is
Here,
small opus on the right side.
here,
Yeah,
this,
yeah, this
or
one.
this one.
Yes,
Okay. This not opacity. There are something else here. You are very near.
this I think there is some abnormality within the vertebral body as well, and there is a calcification focus of calcification.
Okay, give me differential. If I told you this is a chronic cardiac patient since childhood, what
This
should be
can be
it
due to a
should be?
previous cardiac surgery.
Yes, like
This can be like a
hmm.
tetralogy of Fallot, or this can be a patent foramen oval with.
Yeah, correct, correct. Okay, Dr. Amiga, we have enough time.
3 minutes left. 3
3 minutes.
minutes.
Okay,
3 minutes, yes.
let's. Okay, I think we take this one. Okay, yalla. 50 years old female patient presented with dyspnea.
I am provided with the frontal radiograph of an skeletal mature patient. There are sternotomy sutures are noted, which is considered with the previous cardiac surgery. Um, there is an lucency noted on the left side with
Mm-hmm.
selecting the left costophrenic angle. This can be a this cannot be a pneumothorax, but there is a lucency and the lung appears collapse. Uh,
Yes. Hmm.
is there any previous
No,
surgery?
no, this is basognomonic film. Hmm.
Okay, so there is a left-sided
You
biliary effusion, and there is a hesitation